We'll start our spondyloarthritis lecture, Introduction to Spondyloarthritis, kind of off there a little bit. And I always like to start it with this gentleman who was followed in a Canadian VA from just after World War II, and he developed ankylosing spondylitis. As you see, he got worse, back straight, wearing a cane. By 1972, he's quite debilitated. And, you know, he's treated by a rheumatologist and we really did nothing for him. So in 1972, he actually fired his rheumatologist, probably a smart decision. And here he is in 1973. He got rid of his cane, he's more upright, and doing much better, much more functional status, kind of what you really want to do with a disease such as ankylosing spondylitis. It turns out he had bilateral hip arthritis, and so what they did was bilateral hip replacements. And you know, one day, two surgeries, a surgeon was able to fix him, but rheumatologists could really do nothing for him. And so for many years, nobody wanted to go into rheumatology because we couldn't do anything for it. But now in the era of biologics, we've become a hot commodity. A lot of people want to come into our specialty. All right, so next I'm going to show a little video about ankylosing spondylitis.
Axial spondyloarthritis is a chronic form of arthritis causing inflammatory low back pain. It is an umbrella term for the disease spectrum from non-radiographic axial spondyloarthritis to ankylosing spondylitis. The non-radiographic form occurs early and may or may not progress to ankylosing spondylitis. The condition most frequently affects the sacroiliac joints, though in certain cases, joints of the limbs may also be affected. Unlike mechanical back pain caused by sports injuries or trauma, axial spondyloarthritis is inflammatory and generally chronic with periodic flares followed by temporary relief. Inflammatory back pain is characterized by pain that gets worse with rest and better with activity. With mechanical back pain, the pain is better with rest and worse with activity. If axial spondyloarthritis is not managed appropriately, bony growths can develop, causing spinal fusion in severe cases. This can lead to several clinical and quality of life challenges, such as reduced range of motion, higher risk of fracture, spinal curvature, stiff rib cage, and even breathing restrictions. In the past, without definitive X-ray evidence, a diagnosis of axial spondyloarthritis was often overlooked, and the opportunity to treat an immunologically mediated disease early in its course was missed. Additionally, the time between initial symptoms and presence of X-ray confirmed sacroiliitis, which is the hallmark of ankylosing spondylitis, can be a period of several years. Many patients never even develop radiographic sacroiliitis. However, axial spondyloarthritis can be suspected with other classical features, such as inflammatory back pain, inflammation around the sacroiliac joints on MRI, HLA-B27 positivity, emphysema, uveitis, and family history.
And I think as we, look more for ankylosing spondylitis, we're finding much more of it. Now, this is kind of just go back to basics. In a primary care clinic, you're going to find a lot of mechanical back pain, which obviously should be referred to the spine surgery if indicated. But really, what we don't like to miss is the uncommon or mechanical pains, such as spondyloarthropathy, but including infections, fractures, osteoporotic fractures, cancer, referral from visceral pain, and looking if they have fever, weight loss. They don't get better in a month or so. It's something you need to kind of pursue a little bit further. Morning back stiffness with pain onset before 40, that's kind of a continuous process. Is, in my mind, oftentimes spondyloarthropathy till proven otherwise. Nighttime pain, neurological deficits, all things that we need to go. And it's a few examples. So like here's a POTS infection. And sometimes, we do see these periodically as well. Vertebral compression fractures, very common. Back pain lasts 3 to 4 months. A lot that can be done for treatment of them. And also, just like to always mention in a lecture, not to miss, with a lot of proximal muscle achiness, polymyalgia rheumatica, that can go into temporal arteritis, which can cause vision loss. is this an example of a gentleman who infarcted both his temporal arteries, developed blindness from there. We obviously try to treat them before they become blind with very aggressive treatment. And we now have new biologics for temporal arteritis as well, with target interleukin 6. Here, all right, that's my son in Machu Picchu, my last big hike before the pandemic. But kind of just go through spondyloarthritis and the different categories that are here. This is kind of the old classification that many of you probably are aware of, including reactive arthritis, psoriatic arthritis, and others. But they've kind of like moved it now to more axial versus peripheral spondyloarthritis. And in the axial, they include a non-radiographic axial spondyloarthritis, because a lot of these things do overlap quite a bit. And we'll go over some of those X-ray findings next few slides as we go. This is showing here, imaging of the back, and the modified New York criteria for ankylosing spondylitis is shown here with either X-ray changes showing sacroiliitis or spinal changes as well on the two on the right. But on the left, you actually see non-radiographic stage, and that's on the MRI where you see the white inflammation around the SI joint. Let me see if I can point to it there. Here showing significant inflammation on there, indicating active MRI-based sacroiliitis. And even if they're negative, like on the one below, you can actually see that the B27 positive in the right criteria. So what we're trying to do is not pick them up when the X-ray changes, which start after about 4 to 7 years into their disease, but trying to catch them early before they ever develop any X-ray changes, and trying to really use our biologics, modulate, and try to prevent progression from occurring. So non-radiographic axial spondyloarthritis, actually, radiographic is like 2 to 1 male versus female, but non-radiographic is equal between the sexes. And so something that a lot of patients that we see with fibromyalgia actually have inflammation. Many of them have sacroiliitis when you look for it, but doctors just aren't thinking about it too much. Ankylosing spondylitis is quite prevalent. In the US, 6% will be B27 positive, about 0.5% will actually have AS, about a 5% chance if you're B27 of having a disorder occurring. Norway is up to 14% of population B27 positive. Then we do tests in the clinic here, and this is the Schober's test, which should be like about 10 centimeters marking, and then if they lean forward here, it should go to 15, which would be a normal response. In AS with fusion, usually it will go maybe to 10 or 11, maybe 12, but it doesn't go all the way, which would indicate another positive test as well. We're starting to do lots of MRIs on spondyloarthritis. Looking here, so you see some early changes with periarticular bone marrow edema, synovitis, and capsulitis all occurring, causing some minor changes. But catching inflammation around the sacroiliac joint early is our new goal in rheumatology and what we really are looking for here. There's a lot of different ways you can measure ankylosing spondylitis. I kind of like the BATH index, or the ASDAS forms on there. But these are mainly for research studies, but many ways of collecting data on these patients here. And a lot of it goes back to the B27. I'd like to mention just a few words on B27. They were initially developed at UCLA. They had a researcher there who was doing plates of HLA typing on Dr. Terasaki, who was from UCLA. And they found B27 positive in 90% of AS patients as part of a lupus study. They were looking for lupus HLA typing, but found no association. But the fact that the HLA B27 was positive in AS, the initial researchers didn't get it, but follow-up researchers realized that was important, published it, and became quite famous. Reactive arthritis, Shigella outbreak on a Navy ship, 600 cases roughly of shigellosis. Soon thereafter, about 17 developed reactive arthritis, 16 were B27 positive, and kind of the other association with that. Here, B27 is very common in a lot of the spondyloarthritis listed here. Here. And if you look here at the HLA B27 molecule, and the little circle on the inside is the 14 to 16 position, and it changes from a subtype 4 to a subtype 6. It makes it from a disease predisposing to kind of a non-predisposing subtype. It turns out there's like 59 different HLA B27s. Some are problematic, other ones aren't. So it's not just being B27 positive that's important. And they've been recently showing other genes. This is the ERAP1 gene, and showing that in B27 positive patients, if you're ERAP1 positive, you're more likely to have ankylosing spondylitis as well on there. And so it's getting pretty complicated on the genetic basis of ankylosing spondylitis here. And here's just showing, a typical inflamed SI joint before 6 weeks with TNF therapy and 24 weeks, and showing pretty much resolution of early inflammation, which is what we're trying to do in these patients here. And this is, can we stop this? And this is showing here early vertical syndesmophyte formation and eventually fusion and bamboo spine here. What's coming up in the research a lot is, the bone formation seems to be a combination of bone morphogenic proteins, or BMPs, and the Wnt proteins on there. And it turns out that these are very important in the spine. TNF seems to work on the bone morphogenic proteins, but it works on this also through DKK1. And its role is less clear if you can actually block it, if that'll prevent ankylosing spondylitis from occurring with fusion or not. Another thing that's come out interesting is an enthesitis, like Achilles tendonitis, is that in the mouse models for this, the rat models, that if they mix all these IL-23 with inflammation and weight and trauma there, but if they do it in a germ-free environment, no diseases occur. With germs, they develop very typical enthesitis, kind of pointing the role of the gut microbiome, which is being pursued quite a bit in AS as well. All right, X-ray showing classic sacroiliitis are shown here. Eventually, they will fuse. Here's fusion of the SI joints. On this one here, the bamboo spine, which is on all your board exams. As such, we obviously try to prevent this as much as possible here. Just showing that men do get worsening ankylosing occurring more than females. It occurs in both, but the grade 4s are much higher in men here. And this is showing, spine involvement here with, again, vertical syndesmophytes. Osteoarthritis, you get a lot of horizontal syndesmophytes and degenerative changes, but it's really this vertical fusion, which actually, with trauma, can actually fracture and make a very unstable spine. And this is showing here one aspirate of a SI joint, which was seen for TNF, and kind of pointed, the first one is showing maybe TNF is important in ankylosing spondylitis, which subsequent research has totally shown here. All right, so that's kind of my lecture. I went through it pretty rapidly, but I know this is a time crunch, getting 2 lectures in an hour here. This is a climb the Half Dome. There's my son making it up there. It's quite a hike, but really it's kind of like this reminder that you'll see a lot of back pain, but try to not to miss the inflammatory causes of back pain. And here's the top of Half Dome when they made it, so that was a great hike. All right, so that's pretty much my lecture.